Welcome back to the Dr. Cliff Show. In today's episode, we have a special guest, and we are going to be talking about single-sided deafness and the treatment options that treat it. Coming up. All right, so we are back for our live show. This is our 7th episode. I'm Cliff Olson, Doctor of Audiology and founder of Applied Hearing Solutions in Phoenix, Arizona, and I am here with my co-host.
Hello, everybody. My name is Dr. Rachael Cook. Thanks for getting back with us again today. Like you said, very exciting. We've got an in-studio guest today. So on today's episode, we're going to be discussing unilateral hearing loss and asymmetrical hearing losses and the available treatment options for that, including a few of the kind of uncommon ways that a hearing aid can be programmed to provide the most benefit in those situations. So again, after a quick overview on the basics of these topics, because there's a lot of information that goes into this, we will be joined by our very first in-studio guest to get his insight on how to best treat these unilateral hearing losses.
So hang tight, because it's coming.
Definitely, definitely. And jumping straight back into me talking again, we've got to jump into our very first sponsor.
Well, the fans have spoken. They want to hear you more than they hear me.
Oh, goodness. Today's first sponsor segment is going to be for Eosera. And Eosera has got a comprehensive lineup of ear care products for ear wax, ear pain, and ear itch as well. We use the Earwax MD formula in the office to help break up and dissolve wax that just will not budge. So if you're someone that struggles with consistent wax buildup, they have all you need for at-home maintenance. They've got drops to dissolve stubborn wax and bulb syringes to help flush it out. And if that isn't powerful enough, they also have the Wax Blaster, which resembles a kind of a spray bottle to get a little bit of extra pressure in there. They even have the Pro version, which is electric and rechargeable, which makes it super easy to use. So Earwax MD, as well as all of Eosera's other ear care products, are available at CVS, Walgreens, Walmart, most national retailers. But if you visit eosera.com and use the promo code CLIFF20, you will get 20% off your entire purchase.
Excellent. Thank you, Eosera. So let's just go ahead and jump right into it. I actually want to put up an overlay right now of an audiogram because we're going to be talking about two main types of hearing loss configurations today. The first one is the unilateral or single-sided only hearing loss. So if you look at this audiogram that's up on the screen right now, the left ear, which is in the blue X's, you can see that the hearing there is in the completely normal range. Right. And when you look at the right ear, which is actually represented with the red triangles, you can see that that's down in the severe to profound hearing loss range. So this would be a situation where there's only hearing loss in one ear. So this is one of the types of hearing loss that we're going to be presenting today. Right. And then we also have the asymmetrical side of things as well, to where you would potentially have a hearing loss in both ears. They are just substantially different from each other.
Right.
Okay, so we'll be covering those in more detail. Now, Dr. Cook, how does this type of hearing loss come about?
Yeah, right. Got to go back to the very beginning. So sometimes these hearing losses can be congenital, which means that you have them from birth. So you're born with them, whether that was because of a syndrome or a condition that you're born with. And some people have kind of more idiopathic single-sided deafness or unilateral hearing loss, where there's really no reason that they can figure out, that medical professionals can figure out as to why this happened. It just kind of happened. Beyond being born with it, you can also acquire it at some point during your life. And this can be various reasons. Again, any sort of like disease or syndrome, sometimes that can cause it. We also have things like trauma, so head injuries, accidents, and also a condition called sudden sensory neural hearing loss.
And that's a big one.
Huge
because
one.
A lot of individuals who experience that, like, wake up in the morning and they can't hear out of one ear, they're thinking, oh, it's probably just earwax, or that'll come back, I just gotta, get going through my day. And that's like the worst decision that they could ever make.
Right.
And I know that one of my colleagues says that when it comes to that condition, there's not a whole lot of emergency conditions that we run into inside of the world of audiology. This is one of them. So you actually used to work in an ENT clinic. So how often did you actually see this?
It was definitely varying in occurrence, but the main thing to know about sudden sensory neural hearing loss is that time is 100% of the essence when it comes to potentially treating this condition. And so steroids are very generally what is used to help treat this condition, whether it's an oral steroid taper or injections through the eardrum. We won't get into that too much today, but time is of the essence again. And so I want to make it very clear that if anyone ever wakes up and very, very suddenly and unexpectedly loses nearly all of their hearing on one side, it's going to be pretty important that you do seek the care of a medical professional and one that knows things about ears, because I think I've seen too often where patients will go see their primary care or an urgent care and they say, it's an ear infection, here's an antibiotic. An antibiotic is not going to do anything in that circumstance. So it's very important to either have a hearing test done or see like an ear, nose, and throat professional.
For sure, and even if you go in and see an audiologist, when they test you, they will immediately know that this is something that they have to get you referred right away.
Immediately.
And they probably even have connections with good ear, nose, and throat physicians that you can go into. So if you think that that's what's going on, reach out, find an audiologist in your local area, and they can get you steered in the right direction.
Absolutely.
Okay?
Yep.
So we actually have to figure out, what are patients looking to solve, or individuals with this type of hearing loss trying to solve? And I want to put up the overlay here of the head shadow effect, because I think this is something that's very important for you guys to understand. Whenever you have hearing loss in one of your ears, so as you look at the screen here, the left ear on the screen, you can see that that is in this head shadow range. So if you have a sound source that's on the right-hand side of you, by the time that sound fights its way across your head to your left ear, that sound has diminished by 7 to 8 decibels. And you might be thinking, well, is that a big deal? Well, that's the difference between you hearing and understanding someone and being completely oblivious that they're actually talking. So if you happen to have a hearing loss on the right ear in this situation, you're not catching all of the sound from that, and by the time it gets to your better hearing ear, you actually can't understand what someone is telling you.
Right.
Okay? So the issue of not being able to hear from someone talking on your poorer side is one of the big issues. What's another issue that we've got, though?
Another issue that we run into a lot is this idea of localization, or knowing where a sound is coming from. And our brain uses cues from both of our ears to determine exactly where a sound is coming from. It can pinpoint with, supreme
Within a degree, it's very tight.
Super accurate. But when you don't have both ears participating in that for one reason or another, primarily with a unilateral hearing loss, profound hearing loss, your brain is not able to utilize the cues that it's picking up from both ears to create a calculation to determine where is that sound coming from. And so now, when you're hearing that sound, you're noticing that there's a sound, but you might look completely the wrong direction when you hear something.
Right, it's like your phone's ringing off to your right-hand side, but if you can't hear in one of your ears at all, you don't get that timing difference of the sound hitting one ear and then the other, and so you might as well just have no clue where it's at, because you're never going to be able to locate it based on that issue with localization if you have this type of hearing loss.
And there's another effect that is needed, and you can tell them why you need 2 ears for this effect.
Yeah, so we have binaural summation. So this is the audibility increase that you get when you have both ears participating in a listening task, and it definitely enhances your ability to hear and understand what people are saying. And then it goes into probably my favorite one, which figure out how to spell this, is binaural squelch. This is your brain's ability to identify which one of your ears has better speech understanding in a background noise situation, and it can actually focus in on the hearing of that particular ear. So that's a big deal. Now, if you only have one ear, your brain's like, well, I guess I have to take whatever the information is that I get from this one side, and that might not be a good clean signal compared to what you would get from the other ear.
Right. So all of these factors play into how a unilateral or a asymmetrical hearing loss or single-sided deafness or how that's going to impact in your day-to-day life and what you're running into in communication situations, and also regarding environmental awareness.
Yeah, when you combine all of those things together, it really messes with you. So whatever you can do to try to restore those aspects, and we will get to that, but not until we actually talk about our next sponsor. So our next sponsor, if you are watching this show, you are probably wearing hearing aids, or you're considering wearing hearing aids. And so most hearing aids come with a 1 to 3 year warranty. Now, Dr. Cook, how long can they last?
generally between 5 and 7 years.
There you go.
Keeping up on the maintenance.
So what do you do between years 3 and 7 when your warranty is out, right? Things happen with hearing aids. Dogs eat hearing aids. Sometimes humans eat hearing aids, right? Not intentionally, usually. But if something happens to your hearing aids, that's why you need ESCO. So ESCO specializes in providing loss and damage and repair insurance coverage for your hearing aids, so you do not have to pay for expensive repairs before you are actually ready to pay for a new hearing aid. And so their website, if you go to esco.com/Dr. Cliff, Dr. Cliff Show viewers can get a $10 Visa gift card just for entering your hearing aid serial numbers there. And then you can also check the variety of different coverage plans that they have if you want to make sure that your hearing aids are covered after your existing warranty goes out or after you actually use your loss and damage coverage for that. So thank you, ESCO, for that. So, Dr. Cook, we've got to introduce our special guest.
That we do. So today we're being joined by Dr. Scot Frink. He is an audiologist and owner of Salem Audiology Clinic in Salem, Oregon. Dr. Frink is highly regarded in our profession and has presented numerous seminars on hearing technology. He's also considered one of the foremost experts in the treatment of single-sided deafness. When he's not working in his clinic, which is quite literally all of the time, he spends his time with his family at home or making trips out to Arizona to get on a TV show. And so viewers, definitely make sure that you're asking your questions during this, because while we've got a guest on the podcast especially, we want to make sure that if there's a question that he can help answer, that he's able to today as well. So welcome to the show, Scott.
Thank you. And I've always been a supporter of Cliff and his efforts and his team, and really appreciate the opportunity to share with it.
That's great. We're definitely super, super excited to have you on as our first in-studio guest.
That's right. Super
today.
Excited about that. I've known you for a while now, and we've corresponded a lot. We've met at conferences. We talk tech. We talk everything about hearing loss and treatment. So I think you're a very valuable piece of knowledge to have here on the show for our first live guest.
Well, thank you.
I agree. So can you start off by sharing with viewers kind of how you got into audiology and where did this focus on single-sided deafness treatment kind of come from?
Okay, well, my first literal experience with audiology had to do, actually my first impression was my father literally taking impressions on me. He was an audiologist and started the first private practice in Oregon back in 1982. So I kind of just grew up in the business and learned it as we went. I learned all aspects and stuff, and so I did pretty well getting involved with it. So first got my license to dispense hearing aids in 1994, and got my audiology degree in 2004, and the rest is kind of history.
That's awesome. And I noticed that you got your, your dad started in 1982. That was a good year. That was the year that I was born. So there you go. Take that for what it is. But, this focus on single-sided deafness, you are widely regarded as one of the experts inside of our profession with treating this particular type of hearing loss. How did that actually come about?
Well, it actually came about from the demand from patients, meaning that in college I was actually told, oh, don't worry about this, you won't see too many patients who have this condition, and I found the complete contrary to be true.
Yeah.
I remember seeing one research study that it says actually about 1 in 6 patients who actually have hearing loss are actually potentially CROS candidates, depending on how bad their hearing loss is on the bad side. And just a lot of demand for it. Calling me an expert in it, I wouldn't necessarily say that for sure. I won't wear that mantle too easily. But we always had patients coming in. There was technology to help them, which we'll get into later. But I always had patients come in and asking, "What is there anything new for my type of hearing loss?" And for the longest time, there wasn't. And then around 2005, certain patents expired, and then it opened things up, and manufacturers started coming out with things. And I said, "We finally have something." And so I started doing my own internal research studies, sharing or having patients try out the products, because if I'm going to look patients in the eye and say this is the best thing for you, I want to make sure that I've done my due diligence on it. So we did a study back in 2005, 2006 where we had 35 patients, where 3 different types of technology, and from that we learned what's best under the best circumstances. And we've when it comes to CROS technology, we've done about 4 studies along those lines.
So when we start looking at these different types of hearing losses that you would use, some form of CROS treatment for, I actually want to pull up on the screen again one of these audiograms, okay? So from a CROS perspective, if we pull up the CROS audiogram here, what would we be looking at as a provider or as a patient with this type of hearing loss initially?
Well, what you're looking, they have normal hearing on the left side and profound hearing loss on the right side. And I actually find that the audiogram tells a part of the picture, but anybody who has a complicated hearing loss like this needs a lot more testing to be done to determine the appropriate treatment, which again we'll talk about.
And so one of those would be the word recognition scores, correct?
Exactly.
So
exactly.
We have word recognition scores for this, for the crossword scores. So explain what we're looking at there on the screen then. This probably fills in the picture a little bit more for us.
Right. So this kind of explains that, likely with the benefit of amplification in that right ear, even with some amplification going on, they only get 12% correct, but in the left ear they get 100% correct. So they're doing great on the left side. This is kind of like, if you were to use a visual analogy to this would be like being almost completely blind in one eye. And so there's not much that can really be done there. And I've actually found that a lot of patients, if there's more than a 50% difference, they kind of really question how much benefit they're getting from amplification on the poor side.
And I think it's important to discuss, so when we're talking about using amplification or not using amplification, what does that actually look like when we're treating this type of hearing loss? And we do have an image that can help explain this as well.
Mm-hmm. So with the CROS system, again, the better ear is normal. It doesn't need anything really. And absent the hearing loss on the bad side, they wouldn't wear hearing aids. But because of that problem on that side, they need something to pick up and receive the sound on the better ear. So the transmitter picks up the sound on the bad side, sends it over to the better ear, and that better ear is doing the job for both sides. So if they have 100% word recognition on the better ear, they likely will get 100% word recognition when someone is sitting on their bad side.
Yeah, so and that's the important thing to understand here, is that you could be in a situation, in fact, us right now. So Dr. Cook, if you had a case of single-sided deafness in this scenario that you needed cross treatment, if you didn't have the cross treatment, you could potentially hear me on this side, but when Dr. Frink is talking, you got no clue.
Exactly.
Right.
And I think so then with this kind of transmitter hearing aid setup, if I were to be wearing two devices right now, I would have a transmitter on my right-hand side and a hearing aid on my left-hand side. Now the hearing aid on the left-hand side is not amplifying your voice necessarily, because in theory I don't need it. However, the transmitter over on this side, if he were to start talking again, would get picked up and sent over to the hearing aid on this side, so I at least have awareness and understanding of what's being said on my bad side.
And you were earlier discussing the kind of just the acoustic effects of it, but there's also some psychosocial effects, because I have, as an example, a case where somebody was wrongfully terminated from their job because their supervisor didn't realize they were deaf in one ear. Everyone else who was working there knew you just need to talk to the person on the other side. And so the supervisor thought she was rude and insubordinate, so she fired her, and did not really understand what the situation was.
Yeah, that's an extreme example, but you know that it happens.
Happens all the time.
And there's and that's an extreme, but there are other situations where people don't even realize, and other people think that you might be being rude because you're just ignoring them, and that's totally not the case.
Yeah.
So, and these devices, I mean, they look the same, right? I mean, they look totally
identical.
the same. You think it looks like a hearing aid. You put a battery in or you recharge it just like a hearing aid, but ultimately it's a transmitter. The only job that it has in this scenario is transmitting the sound over to the better hearing ear.
Exactly.
Right? So that's one of the cases here, but you actually have some personal experience with this as well. So tell us about that.
Well, as I mentioned earlier, I really started getting into doing CROS technology, CROS and BiCROS and others, back in about 2005. Okay. Well, ironically speaking, in 2010, my wife, at that time of 20 years, developed what's called a vestibular schwannoma, which is a tumor on the balance nerve, and it was growing so rapidly she was bedridden within 3 months of diagnosis. They had to go in and surgically remove it, and in so doing, they also took out her auditory nerve. So now she's completely deaf in her left ear, but still has normal hearing in her right ear. So she's like the poster child for CROS technology. And by the way, she's given me full permission, HIPAA-wise, to share her situation.
That's good. I'm hoping that your wife won't file a claim on you for using her name.
Right.
Yeah, we're good.
Very good. So we've talked about CROS, but BiCROS is a little bit different. So you use the same setup, you have the same devices, but you use them in a completely different way. So let's go ahead and get our overlay of the audiogram for what potentially a BiCROS setup would look like. And what do you see there, Dr. Frink?
Well, in this circumstance, they have relatively normal hearing in the low frequencies, but then they have a mild to moderate loss in the high frequencies. So this is someone who likely has some difficulty in that left ear as well. So they need some amplification on that side to overcome that loss, as well as the transmission from the right side.
And it would also be beneficial to know what they have in terms of word recognition score here.
Absolutely.
So let's pull that up and let me know if this helps clarify anything else for you.
Yeah, so as an example here, the right ear with amplification getting 12%, the left ear 88%. But when we test both ears together, they actually do worse. Because what can happen is the information, if they're getting direct amplification on the bad side going up to the brain, the system can be so distorted that it actually makes things worse. And so direct amplification doesn't help, it actually makes things worse, and therefore they'd be better off not having amplification on that side, but they still need to hear on that side. So in that situation, they need transmission from that side to the better ear so that 88% that you're seeing there is good for both sides.
Yeah, and I mean, in that particular scenario, very bad idea to use 2 hearing aids.
Yes.
So you have, audiologists telling you, like, do not use a hearing aid in that ear because it actually makes you hear worse.
Absolutely.
Than if you were to have one there.
Yep.
I feel like this was one of the hardest concepts for me in grad school when I was learning about cross systems in general, was just this idea of, wait, there's a hearing loss there. Why are we not putting a hearing aid on there? But then when you start getting into the weeds about, word recognition and understanding, it totally makes sense that if there's only a 12% understanding on that side, why would we want to take that sound input or speech input and then crank it up very, very loud to accommodate the hearing loss on that side? But now you're just getting a bunch of distorted, kind of garbled nothing on that side. Maybe sound awareness, but you're certainly not getting better understanding. So just want to clarify that, because
totally.
it's a difficult concept, especially if you have not spent years of your life studying it.
Mm-hmm.
So
it's also another reason why you need to find a provider that follows best practices, because not all audiologists will do binaural testing. And so they'll see this and just say, oh, you just need a CROS system. But at the same time, they really need to ascertain, are they actually going to get benefit from that? Or can they benefit from having hearing aids on both sides? So they need to do their due diligence, do as much testing as possible. The more complicated the hearing loss is, the more testing should be done.
yeah.
Absolutely. And now you have a very interesting story that you shared with me when it came to setting someone up with BiCROS treatment. Something's very unique. I've never heard a story like this.
This is, and I may get emotional on this because it was an emotional situation. So I live in Salem, Oregon, and we actually have several prisons around us, women's prison, men's prison. And so we do test all populations, including some prisoners, and they normally come in shackles, and they've got 2 guards with them. Well, I had this one patient who came in with 3 guards. Now, if you know the movie The Green Mile with the actor Michael Clark Duncan, who's like 6'9", 350 pounds, this is what this guy looked like. And he came in with 3 guards, but he was well behaved the whole time. So he gave me his background, which was he lost his hearing to scarlet fever when he was a kid, and he lost all his hearing in his left ear. In the right ear, he had some hearing loss going on. So he says, oh, don't bother with the left side. You just need to focus on the right side. I said, well, I do need to just verify that, and then we'll just focus on the right side. So we did the test. Sure enough, it was exactly how he described. Then I took him back to my consultation room, where we I like to do demonstrations so that people can hear it. And I wondered if he'd ever had a CROS system, which he had never had before. So I get out a CROS demonstration system, put the hearing aid on the one side, get it all programmed for that side, and then I put the transmitter on the other. He says, what are you doing? I don't need that. I can't hear anything on that side. I said, well, just trust me. And so I turned the transmitter on, and I rubbed my finger over the microphones, and he could actually hear it. And he just came up out of the chair. So then all 3 guards came up out of their chair with their hands on their batons, because they're like, why is he getting up? So, and he got up really fast and stuff too. What did you just do? I can hear on that side now. I said, and I explained to him what a CROS system does. And so he was kind of amazed. I said, so we're going to take this a step further. Okay, go ahead and grab a seat. And so I went ahead and called my front desk person and had him hold the phone up to his left ear, which is his completely deaf ear. No hearing in that ear whatsoever. And he literally started crying because he had never used the phone on that ear. And he says, you don't understand, is I don't think I would be where I am today here in prison but for my hearing loss, because I was a goof off in school. I dropped out early. And of course, when you're growing up in Baltimore, there's not a lot to do other than get in crime when you're a 15-year-old black kid. And so he's explaining this to me. He says, if I hadn't had this hearing loss, I don't know where I would be today, but I don't think I'd be in prison. I mean, and he had never known that this was even available. Yeah. So, and he wasn't that old, and so I knew that the CROS technology was available at the time that he was a kid. So it was quite an emotional situation.
How long ago was this?
This is like 10 years ago.
10 years ago.
Yeah, he was in his mid-30s.
Do you have any idea how much time he had left on his sentence?
He was a lifer.
He was a lifer. Okay,
Yeah.
man.
Yeah.
I'll tell you. So it's stories like that, right? I mean, every single individual that comes in to see us has their own story, and treating a hearing loss, whether it's CROS, BiCROS, binaural fitting, unilateral fitting, monaural fitting, whatever. It's a heavily impactful thing on individuals' lives, and that's just kind of like another one of those really extreme examples of what hearing loss can do if it goes untreated.
Yeah, I've heard too many stories like that, in that physicians often think that, if it's completely deaf, nothing can be done for it. And so, particularly if it's done with a kid, it's like that kid is at a severe disadvantage. I remember reading one statistic that with the kids with untreated single-sided deafness are usually a full grade behind by the time they reach 5th grade when it comes to reading skills. If they're that far behind on reading skills, they're going to be behind on other stuff. And so they have that impediment throughout their entire academic career. Now, luckily, most states now have universal infant screening, so we can catch this stuff early. But for a lot of people, for a long time, they didn't have that, and so a lot of people suffered as a result.
And we still have plenty of physicians, though, that do not agree. I mean, I don't want to say agree, but maybe they just don't understand the research on it, because I have echoed this same sentiment when attesting at an ENT office and finding and diagnosing a unilateral profound hearing loss, and the physician told me, well, it's fine, they got a normal ear on the other side, that'll get them through. And I'm like, it's not about just getting them through. How much access do they actually have to their peers, to their classmates, and if your teachers are always like, okay, turn to your desk mate over on your right, okay, you're going to do this activity, okay, turn to your desk mate on your left. If you don't have hearing on that side, you're now at this complete disadvantage, and you can't constantly be shifting your physical position. Oh, I'll just get up and come over here. And then when you start talking again, I'll just get up and come over here. It's just really hard to do that. And so I just hate this idea of like, oh, there's just one good ear over there and that'll get you through. And it's like, it's not about getting you through. It's about doing well and thriving in that situation. And we have the technology for it now.
Absolutely.
So we need to use it.
And I think that that's why it's so important that we do stuff like this. I feel like being empowered as an individual who has hearing loss to know what your options are and going in and asking about those options, because you might be watching this being like, well, shoot, I was just trying to get information on treating my one ear. I didn't even realize that this technology, it was never presented to me where I went to. And so unless you're empowered with this information, you don't know what you're being recommended or not being recommended. If that's the extent of what you can do from a treatment perspective, you might just say, okay, if that's what I'm recommended, I'm not going to, look into it anymore. But and again, your situation with your wife, she had completely normal hearing, I presume. She may have developed a sudden sensorineural hearing loss on that side, or no, actually an vestibular schwannoma. He said that she developed on that side, and if she was not married to you, who knows what she would have been recommended at that point. At that point, they're probably more considered with like, okay, if this thing grows substantially larger, we're going to start growing into the brainstem potentially, other life-risking things, and they might not even be thinking about this as a treatment option right off the bat.
Yeah, I just say God paired us up 20 years earlier knowing that this was going to happen.
That's perfect. I'm waiting for my wife to develop a hearing loss now too, so I can knock that sucker out of the park, right?
Yeah, I gave her a nice discount, a bigger discount than normal.
Oh, there you go. Yeah, I'll send her up to Salem to get treated by you, Scott.
No, I'm talking about my wife.
Very good, very good. So we got to jump into our next sponsor here. So I'm going to get into the ReSound Omnia. So what is the most difficult listening situation you think that people with hearing loss have, Dr. Frink?
It's always consistently hearing in background noise.
Absolutely.
And hearing specific, understanding speech and background noise.
That's exactly right, because you can hear the noise pretty well, usually in that situation. Well, that hearing in background noise is definitely the number one difficulty that people have when they have a hearing loss. And so the ReSound Omnia was specifically designed for this particular challenge. It delivers 150% better speech understanding than their previous generation technology, which is the ReSound 1. Actually had a patient call me. It's an out-of-state patient who we work with remotely, and he saw this technology come out, and he has the ReSound 1s, and he's like, I gotta try those. And so we are actually getting him set up with the new ReSound Omnia devices. He could not be more excited for it. He wants that 4.5 decibels of improvement in signal-to-noise ratio in a background noise situation. So if you guys want to learn more about this technology, you can check out my recent video that I titled The 3 Ways to Cut Out Background Noise. That, of course, is on my YouTube channel, so check that out.
Okay, we're segueing in here to, so we've talked about CROS, which did we even ever say what CROS stands for?
No, we did not.
Okay, CROS stands CROS, contralateral routing of signal.
That's
Am I
right.
correct on that?
Yeah.
Okay, good.
Take sound from one ear, put it in the other.
Okay,
yeah.
Perfect. All right, I was, right when I went to say that, I was like, I didn't actually run this by anyone to make sure I knew what that was. Yes, so contralateral routing of signal. But we've covered CROS, and then we've covered what we call BiCROS, and that's just meaning that we're obviously putting amplification into the hearing aid side. But we also have a ultra niche, if you will, type of setup for unilateral hearing losses called an AmpCROS. So please tell us what that is.
Okay, so one thing I clarify up front is I did not come up with this. I came across it about 5 years ago when setting up for doing a presentation, and someone had mentioned AmpCROS. I'm going, AmpCROS, what the heck is that? So I did some research on it, and basically it's for people who do have some residual hearing in the bad ear, which they could potentially still benefit from amplification on that side, but still also benefit from routing to the other ear. And AmpCROS itself is not a specific product. It's not something you say, I'm going to go get an AmpCROS hearing aid.
Yeah, no.
What you do is you get hearing aids that can be turned into an AmpCROS system. Certain brands of hearing aids have features in them that allow this to happen, where it's set up so that okay, so we talked earlier with CROS, I'm going to use my wife as an example. The left ear being deaf is, she's got normal hearing in this ear. She doesn't really need amplification on that side. She just needs the routing from the left side to the right. Okay, then you have like this prisoner who needed amplification on the better ear and needed it routed. Okay, with AmpCROS, what it does is it does essentially the same thing that a BiCROS system does, where it's routing it over to the better ear and is amplifying on that side, but is also maintaining a certain level of amplification on this side. And if you might wonder, well, if it's a deaf ear or a severely impaired ear, why would you bother doing that?
And we can give a good example here. Let's bring up the audiogram for what you're referencing here. So again, a situation where there's some hearing loss in the better hearing ear. There's also a substantial amount of hearing loss in the worse ear, but the word recognition score for AmpCROS is where things get really interesting. So let's pop that up on the screen. So I think this is what we're talking about specifically right here.
Well, this is actually more what you do. Looking at this, the right ear gets 36%, the left ear gets 88%. Binaural, they get 96%. So what Dr. Cook was talking about earlier about summation effect, this person is actually getting a lot of benefit from amplification on the right side. So this is someone who could be fit with a traditional bilateral binaural hearing system with just regular hearing aids. But what happens if you can't tell? Let's say the word recognition binaural stays at 88%, okay, and then you can't tell if they're getting any summation effect, if they're getting any benefit from that one side. That's where I personally would default to either fitting them binaural or fitting them AmpCROS, giving the benefit of the doubt that the amplification on the bad side is still going to benefit them to a certain degree. And it can help out in certain other areas, such as if they have tinnitus on that side, then having some type of stimulation going there can help them with the tinnitus. Long term, that person may need to get a cochlear implant. And there's research showing that if you maintain stimulation on the bad side, it actually helps out with the integrity of that auditory nerve to be able to accept a cochlear implant better. So if someone's ever planning on doing that, they really should maintain some level of amplification on that side, but not as much like you were talking earlier, cranking it up. You don't do that. You give a moderate or mild level of amplification, not hitting full target, so they can maintain stimulation, but without it reaching a degree where it's going to actually degrade and make things worse.
And I think you bring up a very interesting point. So at the American Academy of Audiology conference this year, you presented on a variety of different case studies inside of your clinic that you did with CROS, BiCROS, AmpCROS. And I think the point that really got across to the room there was that it is very specific to the test results that someone actually achieves, right? So you can't just go in and look at the X's and O's on an audiogram and say, oh yeah, you clearly need this particular treatment. You don't know that until you run them through a variety of different testing scenarios, right?
Exactly. And so again, with if the word recognition scores degrade when you stimulate both sides, you fit them with a CROS system. If they improve, you fit them with hearing aids. If they stay the same, I would consider doing AmpCROS or fitting them binaural, having them try it out. And there's also other situations. I had one patient, my first patient I ever fit in an AmpCROS configuration, she had what's called Meniere's disease, where the hearing on one side fluctuates. And sometimes the hearing is better, sometimes it's worse. When it's better, she's better off with basically 2 hearing aids. When it drops, she's actually better off in the AmpCROS. So her hearing aids she already had the hearing aids. I just changed it over and added a new setting, which was the AmpCROS setting, which allows her to actually switch between the two depending on what's going on at the time.
And I think that's really an important distinction here. You touched base on it a little bit. I want to make sure that we're very clear about this, though, is that AmpCROS treatment is a way that you configure a set of binaural hearing aids. So you have to have hearing aid technology that actually allows you to do this AmpCROS setup. And there are several different manufacturers out there that will actually do this, but in the cases that you were talking about, like the audiogram that we showed there with the word recognition scores, they might do better with binaural hearing, and then we have fluctuations. Now all of a sudden we need to activate this particular feature and let the patient be a little bit more in control of that, right?
Yep. And actually in some cases I've actually found, and this is where, okay, I don't take credit for coming up with AmpCROS, but I'll take credit for this term, is I call it trinaural hearing, in basically where you're stimulating 3 ways. You're transferring, you're stimulating the good side, and you're stimulating the bad side. I have had some patients come out and they actually do better in that configuration than any other. The word recognition scores go up even further. It's not with every patient. I'd say it's about half the time I see that happen. The other half the time, it's as good as it's going to get. So.
Yeah. Oh man, that is so interesting. I mean, I've had a couple of patients where I have, you see a patient who maybe has this progressive hearing loss on the poorer side, right? And maybe you test them at one point and their word understanding in that ear is, let's say 64%, right? Then you see them a few years later and now you're at 40%. And they're saying, these louder environments or noisier environments, things like that, I feel like the hearing aids are almost kind of making me hear worse right now. And then we see this effect of having that degradation from having essentially too much stimulation on the poorer side. But since they already have 2 hearing aids, if you have a compatible manufacturer, I guess, setting up patients with that AmpCROS and letting them see, okay, do you benefit from just a little bit of stimulation on that side still, but let's still take that same signal that's coming in and let's also route it over to your good side so that you can just benefit both ways. And I feel like I've had pretty good success with it too. You never really know all the way, right? With these types of hearing losses, these are so ultra specific that it's going to depend person by person by person. But you got to try it out.
Yeah, as Cliff said earlier, it's a niche within a niche.
So
it's not a huge amount of people who need this, but at the same time, it is a tool in our toolbox for when it comes up. But you brought up some other things there, where it's like, this is actually, to me, a red flag. If you have, let's say, the pure tones, they're going down slightly, but one side, the word recognition is dropping more rapidly than the other side, that's kind of a red flag that something else is going on, and you need a medical diagnosis to find out what that is to rule it out. It could be a situation like with my wife. And if I ever see a rapid asymmetrical decrease in word recognition, absent too much change in the pure tones, I start suspecting something along the lines of a tumor or something else going on where they really need to go see an ENT. And this is, again, where you need to find an audiologist who follows best practices and is going to recognize those signs and know when to refer.
Yeah, speaking of best practices, you actually are a HearingUp network member. In fact, not only are you a member, but you are one of the individuals who is a part of my advisory board for setting up the HearingUp network. And so you're essentially, I guess, a flagship member, if you want to call it that.
Founding
right?
member.
A founding member,
Yeah.
Right? And if you guys don't know what the HearingUp network is, it is a network of hearing care professionals who are committed to following best practices, just like Dr. Frink was mentioning. So when it comes to best practices and treating this type of hearing loss, what are the considerations? Because I've heard some providers say that they don't need to do verification methods on these. What are your thoughts behind that?
Well, as we talked earlier, the more complicated the hearing loss, the more work the provider should actually be doing. So when you do verification on any hearing aid, you still need to do that with the CROS system, but you should also verify that the CROS transmission is working. So my own system that I worked out is I fit the hearing aids itself to match it to target, but then I actually do a little additional testing where I actually, again, using my wife's left ear, I always just remember it with her, is I actually rotate her so that I'm presenting to the bad side. And then what I do is I test with both sides off and then just the hearing aid on, and then the transmitter turned on, and you can actually see on the screen it incrementally increasing with each step, and the patient can hear it as well, so it's actually another nice little demonstration for them. But it's verifying that they're actually getting that transmission. You were talking earlier about 7 to 8 decibels of head shadow effect. It actually demonstrates that if they had only been fit with the hearing aid on the good side, they would be hearing 7 to 8 decibels worse with just that fitting, whereas with the transmitter on, it moves nicely up into target and matches it.
Yep, nothing you can do with the hearing aid by itself. You have to have the transmitter sending sound over, and you have to verify that you are actually overcoming the head shadow effect.
And what you're really verifying there is that they're going to hear well on that side.
Yes.
Okay, most of the time we're talking directly with people, but that's not always the case. And so if the whole point of a CROS system is to help them to hear better on that side, you need to verify that the transmission is happening properly.
And there's one thing I want to touch base on really quick, because I know we're going to jump to our next sponsor segment and then into Q&A. So if you guys have not asked questions on Q&A, get those questions out there. This is like a one-in-a-lifetime opportunity to ask questions to Dr. Scot Frink on our show. Actually, he'll probably be back on in the future, but make sure you ask your questions. Localization ability, how much benefit do you get with CROS and BiCROS from a localization, identifying what direction sound is coming from?
It's not great, but it's better than if you don't do it. So meaning if you just have a hearing aid on this ear and you're stepping off a curb and says, watch out for that bus, which direction are you going to look? You're going to look to the direction that you can hear more on, okay? Whereas if you have the CROS system, you stand a better chance to hear it coming from either direction. So localization is absolutely not as good as if you had normal hearing on both sides, but it is better than it is if you don't.
Perfect. Thank you for clearing that up. All right, so who do we got next?
We've got Sound Oasis. So if you have tinnitus, you know that quiet environments can definitely make that more noticeable. And Sound Oasis has an entire lineup of sound generator products to help out with that, including their BST100, which has built-in sleep sounds and Bluetooth audio so that you can actually stream your own sounds, whatever kind of sounds that you'd like. You can build your own custom sound machine actually by selecting between 10 and 20 different sounds from the Sound Oasis sound library. And this speaker also streams music via Bluetooth from your mobile device or your computer so that you can enjoy your own music, podcasts, whatever you'd like to listen to help out with that perception of tinnitus as well. I have this exact speaker. I use it every single night. I love it.
My mother has it too. Just throwing that in there.
Yes, of course she does. And they also have a great lineup of apps as well available on the App Store. And so you can try those out. Just type in Sound Oasis. They've got a variety of different nature sounds, background sounds, soothing sounds, things like that. The light version is free, but any Sound Oasis customer is able to upgrade to the Pro version with the purchase of any of the products. And so once you link that product up to your phone, you get access to that Pro version. So be sure to visit soundoasis.com and use promo code SLEEP. That will get you 20% off any of their products.
Awesome. Thank you, Sound Oasis. So, of course, my favorite time in the show, which is Q&A time. We've got Kelsey back here for Q&A.
Yes.
And so I'm really excited to see what kind of questions we had come up from this particular episode.
The questions were actually out of this world, and we've got a couple complicated questions, so we'll get through what we can, but I think that these are really important questions to ask, even if they take us a few extra steps to answer, okay? So this first one is from someone on YouTube saying that I have a high-pitched tinnitus in my right ear only because that's the ear that I one day woke up with a sudden sensory neural hearing loss back in 2020. Can a hearing aid help silence that tinnitus in my ear? My audiologist told me that the longer I go without hearing aids, the more likely the auditory nerve is to atrophy and a hearing aid will no longer help. I really want to know if my audiologist was right in that the auditory nerve can atrophy. It almost sounds like a scare tactic to me. Buy this hearing aid or you'll suffer later. So there's a lot to unpack in that question, but I think that all of these points are really important, and I think mostly that this question was directed toward you because I got it just as you came on to the camera. So I'll have you, Dr. Frink, answer this first, if that's okay.
I'll do my best.
Sounds great.
There is some research showing about auditory deprivation, and that if you, it's kind of like, if you did if you're not lifting using one arm, that arm's going into atrophy if you're having the other one do all the work. And that's actually putting more stress on on the better arm because you've got that going on. When it comes to hearing aids and tinnitus, my personal opinion is that you don't use a hearing aid to treat tinnitus. You use a hearing aid to treat hearing loss. But there's a very common side effect, I call it a fringe benefit, that when you have amplification, you're actually going to often help out with the tinnitus as well. Because if you think about it, with the tinnitus going on, the reason the brain is focusing on the tinnitus is it wants to be aware of sound around it for safety reasons. It's thinking, is that sound important? Do I need to focus on it? And over time, you can habituate to it it reaches the point where, the brain says, I don't need to focus on that so much. But it takes time to recover that.
Right.
So if you have a hearing loss on that side, or both sides for that matter, and you hear less of what's going on around you, your brain's going to focus more of what's going on internally. If, however, you have amplification, you hear more of what's going on around you, your brain focuses less on the tinnitus. So it can help out with the tinnitus, but I focus first and foremost on what the hearing aid does for your hearing. And if it has a nice side effect of helping out with the tinnitus, then great. I find that 80% of the time that is the case. 20% of the time, patients with tinnitus, if it's fairly severe, they need something more aggressive. So there's manufacturers that have special features in their hearing aids to help out with that.
Right.
So, but just usually amplification by itself. I find most of my patients who checkmark tinnitus on their case history form, if it's a milder case, they usually after a few weeks of wearing the hearing aids are doing pretty good. 20% of the time, they need something more.
Right.
Yeah, I mean, this is such an interesting case. We were talking about one kind of similar today. So, but this is one of those moments where like word recognition scores are going to play a huge role in this. We've got to do further testing beyond the audiogram to determine if amplification on that side would be beneficial in any sort of a way, and if not, what are the alternatives there. We were talking today, and we will talk in future episodes about what are the more surgical options for single-sided deafness or an asymmetrical unilateral hearing loss, profound hearing loss. And of course, there are cochlear implants and bone-anchored hearing aids and things that can be done in that way. But it's just so important to look at the entire package of what's being presented. And of course, we're only getting some of it there, but to know what could be done on that side. And if they truthfully had a sudden hearing loss on that side and their word understanding on that side is completely diminished, then at that point, are we doing more of an AmpCROS setup to get a little stimulation on that side and also get the transmitting? I mean, as you can tell, it's extremely hyper-specific. But,
Right.
Moral of the story with this question is that it's not a bad idea to treat this hearing loss, or at least attempt to treat the hearing loss to see what benefit that you do get. Scare tactics aside, the recommendation's a good recommendation. You treat it, right? You treat it, and like we've said numerous times before, no one has ever attempted to treat their hearing loss and just totally regretted ever attempting to do so, right? So always a good idea. I would say that if you got that feeling from that provider, maybe they're not the right provider for not explaining things in a way that you could actually understand, and maybe you need to find a provider who can communicate with you in a way that you can comprehend what they're trying to get across, instead of feeling like it's more of a sales tactic.
Right.
Yeah.
One more thing on that is that you can, most states have it where you can try something. If you're not satisfied, you can return it.
Yeah.
And so just make sure you know what those guidelines are. It's all about consumer protection. And so therefore, if you try it and you perceive some benefit from it, then great. If not, then take it back. But don't give up, though, too. Just because that didn't work doesn't mean there's not necessarily something else out there that might.
Exactly. I mean, just in this short podcast, you all have talked about several options, and when one doesn't work, there are other options available. And so it's important to have that communication as a solid foundation with your provider. And so that's always important. So if you're not with the right provider for you, that's okay. There are more of us out there. So that's a really good point. Thank you. So I have another question about apps and CROS and BiCROS. So we had one commenter ask about the lack of the Phonak app being compatible with the CROS. Is that going to change, because he's considering changing his entire hearing aid setup because he needs control over his CROS?
Yeah, I mean, they have said that they are going to make it compatible. Whenever that comes, we don't know. They just released a new line of hearing aids a year after they released the CROS option for their Paradise line of devices, and we still do not have CROS compatibility with the app. I think that it's probably coming up, in maybe, if we're super lucky, by the end of 2022, most likely sometime in 2023. The question becomes, how long are you willing to hold out for that? And right now you're treated, so it sounds like they're treated right now. Keep going with that, and if you feel like it's a strong enough reason to leave and go with a different manufacturer, then that's a decision that they have to make for themselves.
I would also say, just like, what are you looking for out of an app anyway, right? Because we know that we can generally do volume adjustments. We can generally set CROS, microphone balance, and program changes from a button on the hearing aids themselves. And beyond that, I mean, you do start getting into some of the nitty-gritty on, small, like, speech focus or background noise reduction or things like that. But my hope would be that the devices would be programmed in a way to where you're not having to make too many adjustments on your own. So at that point, it's kind of like, well, are the devices optimized in a way where you can utilize the buttons to the best of your ability, and maybe you don't need the app? And if not, then okay, you can consider changing at that point if you want to. But
also look at other trade-offs that you might have. If the app is the only thing that's wrong, but everything else is going well, you have to think about, if I switch to a different brand, what am I going to give up? People ask me, well, what's the best CROS system? I say, it's the CROS system that works. Now, what's really more important is, what is the best hearing aid for your particular hearing situation? Certain manufacturers do better with the sound quality of music. Certain manufacturers do better with the performance and background noise. You need to prioritize it. The CROS transmitter is pretty straightforward, and most of them work pretty well. But how the hearing aid works is actually the more important question in this situation. And if the app is an important thing for you, if it's a deal breaker, then keep that in mind, or then follow up on that, but also think about, well, if I switch to something else, what will I potentially give up?
I think there's too, we see it all the time, where sometimes you just don't like the way a particular brand of hearing aid processes sound, and you don't like the way it sounds. And so again, the hearing aid is meant to help you hear. And again, just to your point as well, if the Phonak app or an app not being compatible with CROS in general is the deal breaker, absolutely. But remembering too that, if you're happy with how things sound and they are working for you, cost-benefit trade-off
for sure. We can probably do one more.
Okay, I have so many.
Maybe sorry. Two more. We can
maybe
do two more.
I'm sorry to everyone who doesn't have their questions answered, but we will get to them too in the comment section if we need to go back after this video and comment our responses as well.
And we will be doing future episodes where we're just straight answering all the Q&A questions.
Yes.
So keep that in mind as well.
Yeah.
Okay. This is sort of off topic, but it was asked by several people. Why do PCPs ask if you're having your eyes and teeth examined regularly, yet you never seem to be asked if you've had your hearing tested recently? Especially when, and this was an added from someone else, especially when they know you have a hearing loss, and in particular, single-sided hearing loss.
I have so many feelings.
Is it okay to say I don't know? Like, I can't wrap my head around it.
I got it.
Do you know it? Go ahead.
My opinion, is that hearing loss is invisible. You can't see it, you can't feel it, but you got problems with your teeth, you feel it or you see it. We're very visually oriented creatures, so we can recognize vision problems faster than we can recognize hearing loss. And so I think they're just projecting their own experience. Primary care physicians are projecting their own experience. They also don't recognize the psychosocial effects on communication and socialization, academics, vocational issues and stuff that hearing loss can have on someone. They don't know that. It's not necessarily their fault, because in med school they're not trained on it. Okay, if they're not trained on it, it's not relevant, right? It's not important. Well, that is where it is incumbent upon us as the hearing professionals to get information to those physicians to get them to recognize it better. Is if 1 in 6 people have hearing loss by age 50, treatable hearing loss by age 50, I would, as a physician, I would actually make it a standard protocol to test their hearing. You turn 50, you're going to get this test and this test and this test, and one of those is going to be a hearing test.
Yeah. Oh, I so wish that it would get added to the standard battery. I think too, there's just a lot of stigmas around hearing loss. I think people think it's funny sometimes when they say like, oh well, yeah, sometimes I don't hear my wife, but I don't know if that's just because I don't want to. It gets more laughs around it, and so I think sometimes it's easier for it to kind of just get pushed under the rug a little bit and not taken as seriously. But when you can't see, right, it's like, oh, we got to correct this immediately. Like, you're not seeing well. You're not seeing all the way. Like, we got to fix this. But when it's hearing, it's kind of just, I don't know. There's just not the same.
Well, you know, and Dr. Frink, you bring up an interesting point of that it's our job to educate, to make sure, you know, with the physicians are recommending this stuff. And you guys know, I spend very little time trying to convince professionals that they should be doing anything, right? They're going to do what they're going to do, in my opinion, unless an individual who has a hearing loss goes in and actually requests it. So it becomes an empowerment thing, right? Are you going to advocate for yourself? And that's what I'm all about. I think that we should be educating ourselves in any medical condition that we might have, and actually asking our professionals, asking our hearing care professionals, asking our physicians, you know, I'm having difficulty with this, what can I actually do? And you be the one to bring it up.
Right.
I mentioned earlier how so many people have hearing loss by age 50. Well, it's more like 1 in 3 or 1 in 4 by age 65. So I'm dating myself here, but back in 2000, Medicare instituted the Welcome to Medicare test protocol, which physicians are supposed to do. And it looks like at the top 10 things affecting people over age 65 is hearing loss. Number 6 is tinnitus. And so physicians are supposed to be screening for this in the elderly, but hearing loss affects all ages. 1 in